And congratulations, you are now on session 3 at some level of conversation that we're going to have today. Um, my name is Kathy Gruss, and I'm going to be one of the co-facilitators for this breakout group. And
I'm Lucy McGowan.
and she's going to help out. And we have the honor of having John Orsini as well to be part of our panel. Our overall goal for this afternoon is to develop a strategy to overcome one key challenge in the area of assessment of the interprofessional learner from the education to workplace. And I just want to highlight the word assessment that came up in our last group, that we've gotten so excited about discussions about challenges and opportunities that sometimes we've forgotten to really focus on the assessment piece. So I'm going to charge all of us in the room to make sure that our discussions today keep circling back to that particular point. The specific task for this group is going to be focusing on the individual level. So you've now had opportunities to have conversations about challenges at the policy level, challenges at the institutional level, and now we're going to bring it down to the individual level. So what we're going to be doing today is we're going to discuss individual level challenges and opportunities, again, related to the assessment of the interprofessional learner from education to workplace. Before we jump into that, we thought it might be helpful to spend a couple minutes telling you what's come up in the previous two groups so you have a context for what some of their discussions have been and where they've kind of landed with respect to the challenges that they've identified. And I will say, and I don't know what your experience has been in other groups, it was really hard for them to come up with one challenge. There was a lot of energy. Well, there's so many challenges, so many opportunities, but we really do want to have a focal conversation so we leave here at the end of the day feeling like we've really helped move one particular issue forward rather than diffusing by covering a number of issues. The first group that we had here, again, was focusing on the policy level, and where we ended up landing in terms of a challenge they'd like to put forward really had to do with the systems that are responsible for accreditation. And they wanted that defined very broadly, not only entities that oversaw accreditation of education and training programs, but also entities that oversee quality mechanisms for healthcare settings, such as the Joint Commission. They thought that that would be an important leverage point for policy discussions to try to infuse more energy and enthusiasm for interprofessional education and, of course, assess high quality assessment of the interprofessional learner. So that's the recommendation that they're suggesting be considered to move forward.
Yeah, and moving on from that down at, sorry about that. I've done that every single session. Moving on from that, stepping down a level to the institutional level, again, it was very hard to distill the discussion and pick one big challenge, but what we came to was one of the major challenges is having the ability to assess students in perform high quality assessment of students in a practice setting before those students move on from the programs to the workplace. And so assessing students, performing a high quality assessment of students would be done within the context of an institution that values assessment and values assessment of the interprofessional learner.
So what we'd like to do in the very short time that we have together is we're going to do 3 different things. We're going to spend a little time talking about the issues of challenges at the individual level. Then we're going to shift gear and talk about opportunities at the individual level. And then we're going to close with coming up with one challenge at the individual level. So to facilitate our discussion about the challenges, what you see up here is a list in no particular order of ideas that were generated by forum members prior to this meeting to help with the discussion. We're not limited to talking about these things, but I thought it would be helpful if we just take a look at these and see which of these people resonate with, and please feel free to jump in. If you see something that you're intrigued about, go ahead and jump in and let's have some dialogue about that, because that's the whole purpose of this part, is just to see where the energy is related to the challenges. So the first one we have up here is that self-assessments are problematic. We certainly spoke about this in the morning session. The second one is dysfunctional, resource-poor clinical learning environments. The third one, and this has come up a number of times in our discussions, finding clinical placements that really embrace IPE. The fourth one, assessing team collaboration in education that closely resembles real practice. Number 5, focusing on individuals rather than the collective abilities of the group or team. Number 6, inconsistent scoring rubrics from different assessors creates confusion. Number 7, consistent evaluation of learners from all disciplines. Number 8, measuring the learner in the workplace. That involves patience. And number 9, longitudinal assessment of IPE. So we have a big list there, and I'm sure folks in the room have some other ideas of things that we should put up there in terms of challenges. So with that, I'm just going to throw it open. What do people think?
Yeah, I'm a guest here, so take my comments with a grain of salt. But I think one of the biggest difficulties that individuals have coming out of training and getting into the workforce is identifying their role models. And so part of the difficulty in setting up IPE, et cetera, is what role models have they focused on, and how are they continuing to focus on? And if you're not accommodating that in whichever institution, then your IPE is not in synchrony with what their ongoing real world is.
The challenges that are up there, do any really resonate with folks? Anybody have a problem with any of them?
My thought was that self-assessments shouldn't be used because they are not perhaps as valuable as other types. It also struck me that you can do something about assessing this in the educational setting, even though it's not the same as the clinical setting. And that seems to me that is a first step, that in the process of training, if it really incorporated attempts to assess and develop interprofessional behavior, that would be at least a start. But you would never be able to, as an educator, assess within the workplace because you're not there. So on some level, that just says to me, I mean, it's like you have to have a handoff. You try to do the training initially, you try to do assessment and raise people's qualifications, then they get into the workplace, and there has to be some way in which, first of all, there's assessment, but second of all, there's consequence. But you don't want it to be where the consequences are just punitive. So if somehow there has to be built into the settings that need this type of knowledge base, that they have to have some responsibility. And we talked about that there might be some early on in the clinical settings, but even there it's difficult and so on. So somehow, how do you link it with some outcome that makes it more likely that it would be supported and happen? And that seems to me a critical step that has to somehow be addressed, but I don't know how.
Other comments?
I have a question. Is the learner, are we assuming the learner is just the student, or could the learner also be a faculty member?
I think we could interpret this as just a comment that was brought in from one of the forum members. I would presume it means the student, but if we want to define that broadly for the purposes of this discussion, that's fine.
Partially because I do think one of the challenges, in a sense also at the individual level, although it's institutional, is the whole issue that you're mentioning about role modeling, but the whole issue around where are the faculty around interprofessional education and the clinicians that the students may be then studying with who are not necessarily faculty. So I at least at our institution, that we find the challenge more there than with the actual students.
I think you've raised a really key point. And in addition, many of the assessment methods that you would use in a clinical setting will rely on the faculty to be
Yes,
the primary
exactly.
assessment devices.
Exactly.
It's not so much the form they fill out.
Exactly.
So getting the faculty online and in with the culture is absolutely critical.
So for me, anyway, I personally see that as one of the most significant challenges that we're addressing.
Right.
That I think this IOM Global Forum could address.
I think maybe it's somewhat similar to Liza's
Yeah.
comments, but I think the finding IPE clinical placements is not so much the issue as finding appropriate IPE clinical placements, or how we assess whether a placement is an interprofessional placement or not. Often places will say they'll take students and they'll provide them with some team experience, but they're not really functioning very well themselves. So if we could come up with some common rubrics to assess whether clinical placements actually are offering truly interprofessional placements, and then from that build to the individual and the collective assessment, plus the faculty development, I think perhaps we might nudge ahead a little bit further on the work-based assessment.
Yeah, thank you.
I'm Gail Rue from Texas Women's University. I'm also serving as a guest. It does link with the other comments, but representing the university environment, I would also say that we need more help from organizations such as IOM to work with the structures, the financial structures of the universities. Now, this is a big task. However, currently I am involved in a HRSA IPE project, which has been marvelous, nursing, OT, PT, and nutrition science. However, the grant funds support that. But ordinarily, we function in Texas under what we call a formula funding premise. And so each of the colleges somewhat have to function on the program fees from their student base. So once you start an interdisciplinary, transdisciplinary approach, and you have floating faculty and floating students, so to speak, the formula funding becomes a nightmare, and the deans can become very territorial about what college receives these program fees. Even though philosophically and from a pedagogy point, we do promote IPE, in the end, it can also become a problem regarding the accounting of the faculty and the student for workload and formula funding. Does that make sense?
I'd like to respond to two, and I hope that we're not categorizing resource-poor clinical learning environments as dysfunctional ones, that those are two separate things. But we also, resource-poor clinical learning environments are the reality, and that's not going away. And our FQHCs are a perfect example of how rich of a learning environment that can be for students, and I think we need to honor that. And also, if we really think outside the box, a dysfunctional learning environment can also be a rich learning environment, and we can really capitalize on post-conference clinical and all the tools that we bring to our toolbox to really talk about what happened on that particular day or clinical rotation.
Can you use the mic because we're webcasting?
Thank you. I'm also a guest, like the gentleman over there. I hope my comments will be taken in good faith. In defense of self-assessment, I know it's problematic, but I think it's something that we cannot avoid. The educational outcomes, probably matter a lot. If one of the outcomes is to create a lifelong learner, then it's absolutely essential that teaching them how to assess themselves properly is an absolute must, because you cannot be a lifelong learner unless you're a self-directed learner. Yeah. You cannot be a self-directed learner if you cannot assess your own strengths and weaknesses. So I think we need to deal with self-assessment. And in the process of education, we should teach the interprofessional learner how to assess himself or herself. I think it's problematic, but it's essential. It's an evil that we have to learn to live with.
Thank you for speaking to that.
Yeah, I agree with that. I think self-assessment is always going to be necessary. And a way of strengthening that is by doing 360 assessments. So you're not only asking the individual, but you're asking those who the person works with. And having a discussion around the differences between those two is also, if there are differences between how you see yourself and how others see yourself,
is also an amazing learning opportunity that can be done in a very supportive way. And it's formative and not summative.
Thank you. In sort of listening to the conversation, my eye got drawn down to the bottom then, and the longitudinal assessment. And it actually, given our conversation, winds up being a longitudinal assessment of not only the individual, but those faculty, as well as the institution in which everyone is being housed, because that is an ongoing evolution for all of those components. And whatever external forces are coming at us from either the clinical delivery side in order to sustain, or the educational side, or accreditation, those will all be changing and very dynamic over time.
So while we're on the longitudinal topic, it seemed, and I'd wanted to ask this morning, but we ran out of time. This is a technical question that I honestly don't even have a clue as to the answer to, so John and you folks may be able to. But it seems to me the longitudinal integrated clerkship or similar models at the residency level give us an opportunity for assessment around iterative assessment over time, and that changes the N of the assessments. And so my question is really, does that replace to a certain degree the volume needs of the N for other kinds of assessments, or are they completely independent?
I'll leave that to you.
Thank you. That's a good question. And there's no firm answer to it, but it seems to me like in a longitudinal assessment situation, you have an opportunity to investigate growth in a way you don't otherwise. So I think the opportunity there is a progress kind of testing, if you will, throughout that period of training. That's one model. Another model is that you focus, and this model I prefer a little more probably, is that you focus on formative assessment throughout that integrated experience and then do something more summative at the very end. So that workplace-based formative assessment becomes most of what you're doing, and then you do something at the end in order to clean things up and make sure that you've captured the people you need to capture. Did that help?
I was asking John whether it would really help in either of the two models that you articulated. It seems to me, in my simplistic view, that it would help to have more longitudinal assessments rather than these scattered, independent assessments that have little contextual value, et cetera, et cetera.
Yes, because you end up with if you do it in the way we're doing it now, you end up, as you said, with a hodgepodge. Sort of a strange collection of assessments. If you're doing it in a longitudinal fashion where there's some continuity, both of faculty, which is important, especially for the formative piece of this, but of patients as well, I think you have the opportunity to do much more education and assessment that helps education in that setting.
So I can talk of continuity of assessment.
Yes.
As additional continuity around learning, patients, relationship building, and
Yes.
assessment.
Yes.
So then it would seem to me that one of our key recommendations ought to be at the micro or meso, or however you want to think about it, level, that longitudinal assessment and longitudinal curricula of various types would help greatly with the assessment problem.
Yes.
Is that a fair assessment?
From my perspective, yes.
I'm going to quote you, thank you.
Yeah, please don't do that. That'll undermine the credibility of your argument, you know.
Thank you. In the sake of time, I hate to shut down this discussion, but I want to shift us a little bit to talk about the opportunity so we have a chance to circle back and come up with our challenge that we're going to recommend moving forward. So I'll again walk you through the opportunities that have been suggested by forum members for your consideration. And please, again, jump in as you resonate to certain things and don't hesitate to bring forward new ideas for discussion here. So the first one here in terms of opportunities is using simulation to bring provider groups together for learning. Number 2, develop a depository of toolboxes of IPE, IPP practices and skills. Number 3, student portfolios that include self and peer assessment. Number 4, evidence from education can impact collaborative practice and patient outcomes. Number 5, contribute to safe patient care. And number 6, assess collaborative competency of the health professional. Seeing some mixed faces here. I know it's late in the day. Oh, go ahead.
May I ask a question?
I'll try to answer it.
I think it's more, if you don't mind, if I could ask John the question. John, you mentioned progress testing. Do you think that progress testing would be an opportunity to assess, to examine a strategy for assessment that could show changes in collaborative practice skills over time?
Yes, I think it could, but I think that the applications to date have been with multiple choice questions usually in that model, and trying to switch that over into a simulation or a workplace-based assessment structure still faces a few challenges. Nonetheless, I think that even in some of the crude things we've done in terms of observation with the mini CEX, you can see growth throughout the first year of training. I would imagine that you would find similar results in this area as well.
So maybe my curiosity, just given the challenges we spoke about and thinking about the opportunities that are listed here is, and maybe this is implicit, is potentially we've lost the team assessment focus. So when I look at what's up here, what I see is, again, a focus on individual assessment. And I was really struck this morning by a question, I think it was Jordan had, about the assumption potentially that individual competence relates to team competence. And I don't know that that's true, but I'm curious about that. So I'm just wondering, based on the conversations before we came into the room, is it implicit that the team piece is still here, or have we moved back to just the focus on the individual?
Again, this is a non-random sample of responses, so I think it's up to this group what focus you want to take, and I really appreciate that observation because I'm looking at this again. I would concur with you that we've shifted very dramatically to the individual.
So the use of simulation, I think, clearly is a trend that's established. The technology is continuing to evolve quite rapidly, and several simulation and education centers around the country are already beginning to move into team-based clinical scenario testing. And so I think this is probably, of the list, the one that represents the strongest potential because it gets the learner and the faculty, quite honestly, to a stage potentially of having a reasonably good set of cognitive skills as well as technical skills before they're actually even onto the patient care. And that's what we need to continue moving away from, that see one, do one, teach one, and a premature interface of the students and the learners with that patient and keeping them safe.
I also think, to follow up, that one of the things mentioned this morning, the idea of the students together from different professions forming a team that does follow a patient or family throughout their 3 or 4 years of education is an opportunity for us in assessment. If we can assess that and develop the longitudinal framework for assessment, I think we have another opportunity.
I would also like to reiterate what I said earlier today. You know, I come from an academic setting that is not tied to a medical school, that doesn't have other healthcare professions. So for me, simulation is the only way that I can truly bring or have them view simulations that have been created, donated into a resource pool or into a toolbox that we can use. So very important.
One of the trends that we're noticing in Canada, I think where you can attest to this, is the change in language in the health professions legislation to include interprofessional practice. And I wonder if that's one of the opportunities, thinking back to the comments around role modeling, that if regulatory colleges are now requiring inclusion of collaborative practice or interprofessional practice in their continuing competency models, that may be one way of slowly changing the role modeling that would positively influence the students.
I was just going to comment on the first item again on simulation. I think it also allows for the individual assessment. I know there was the earlier comment that individual assessment shouldn't be encouraged, but I actually think it, as another commenter said, it should be encouraged. It allows learners to self-regulate how they learn in that simulation setting, and is another form of intrinsic feedback in addition to the feedback they get from faculty. So that's why I think simulation is a very strong thing moving forward.
I want to dovetail off that a little bit, and particularly a statement that was said over here, just individual competence relate to team competence. I think you were saying that, or you were. Mm-hmm. I think that's really important because if you look at healthcare teams, they change. The team on Monday looks different than Tuesday. The AM team looks different than the 2 p.m. team. So we have to have some kind of individual competence coming into the team. That's where I think those IPE competencies are very important, about roles and responsibilities, our value, ethics, teamwork, and communication. If that foundation's not set and we come in and then we start collaborating, that's a problem. So I just want to make that comment. And simulations do help, I think, in getting that team together. Then the beauty is the debriefing and the showing the evidence afterwards when you can reflect in and on the scenario and the practice.
I'm looking at the clock here, and I hate to move us along so quickly, but we do need to try to articulate a challenge for the individual level. So we've had a little bit of time to think while we've talked about the opportunities, and let me see if I can pull together some of the pieces that we talked about when we earlier spoke to the issue of challenges. They grouped, I think, in a couple different areas, and forgive the liberties I'm taking with language here. It's our third group. I'm trying to be as articulate as I can. One, I think, spoke to an issue that came up in other groups related to the culture within the academic institution, and we talked about here, how invested are the various faculty members in interprofessional education first and foremost, and depending on where they are with that, what are the tools and commitment they have to assessment within the educational setting, and then how can they serve as role models depending on the degree of investment they have in this. We talked about what in fact is interprofessional education. Do we have a rubric that we could assess the characteristics of different practice settings to see to what extent they're embracing what we would have a common core consensus on is IPE. We talked about issues related to financial resources, both at an advocacy level, within institutions to help get a commitment from administration to IPE programs, and the reality that limited financial resources limit opportunities for clinical training environments for our students. There was a couple nice comments about self-assessment and how we might have an imperative really to train people to be good self-assessors, and that cultivates lifelong learning attitudes, and we could certainly embed that in tools such as 360 evaluations. We also spoke quite a bit to the issue of longitudinal assessment and why that might be a very good opportunity not only to assess the individual learner but to provide some data about the impact of the IPE program, as well as perhaps collecting some data about the faculty that are teaching in those programs. And then I thought there was a very nice comment to the issue of that word dysfunction, which I also resonated to, and how that could be an opportunity if our students are, in fact, in teams that are performing less than optimally, how we could use that as a teaching tool in terms of having debriefing with them about what's happening and why that's less than ideal. So hopefully I've captured some of the conversation, and I guess our job now is to see, out of all these things that I think we'd all agree are important challenges to be addressed, what seems to be rising to the surface that you'd want to make sure doesn't get lost in this conversation moving forward.
I've been noticing that in any of the sessions I've been at, I've been a little bit surprised that the the entity of crew resource management in the airline industry hasn't been brought up because, and I'm sure everybody in here, most people have heard John Nance speak about that, and it's pretty popular in healthcare industry now as we borrow from many other industries such as the military for SBAR and so forth, that we don't reinvent wheels, but we take those existing wheels and say, you know what, if we want to evaluate how well people are performing interprofessionally, then that needs to be happening before we can assess how well they're doing. And I have often thought, when John Nance told the story about, because I was always afraid of flying for many years, and that was kind of reinforced when he said, every time you get on a plane, think about this at 35,000 feet, that all those people in there have probably never worked together before. And they're only working that shift, that flight. But because they've been trained in such a way that they know whose job is what level I need to function at. I don't care if I have an opinion about performing this job this way, I must follow protocol. Then you've got patient safety, collaboration, interprofessional, you get it all. And it's been proven that it can be done. And I think that there is a big road for pathway to success for us in breaking down some of our barriers and seeing, you know, it's already been done. Let's do it, you know? So I just thought that fits in here. Maybe not, but I think it probably does.
Well said.
Well, I love John Nance, and I love his stories and everything, and yet I always come back, if you don't remember, the pilot is the first on the scene of the accident, so they have a little vested interest, whereas patients aren't quite there. But I'll take your comment and try to put it into the challenge, because I think part of what we need in healthcare is, yes, we need to learn from other industries, but there's a little bit of jaded skepticism coming in as we review how some of these other industries do or do not work in healthcare. So part of the challenge then is, how do we create these innovative approaches that are created by healthcare, that's relevant for healthcare, that works in healthcare? That's the challenge.
I do think the lessons that have been, it's only been recently that story holds true, because as you know, there are several people, the most negative consequences be underground if you're in aviation as the passenger. And it's only been in the past 5 years that they have overcome the pilot versus co-pilot communication issues. And I do think that there's a lot to be learned from that. They pretty much have eliminated the opportunity is there to speak now, and whether you're in surgery or in a clinic or wherever, I do think we can learn from that. So.
We're just about at time, so can I get a general consensus from the group? We talked about some really important things, but I don't feel like there's any one thing that's rising to the top. We want everything.
I think the longitudinal assessment is probably one of the most important things, because if over time we don't know that it's making a difference at the individual or the institutional level, then how do we know that we should continue to do it or not?
There's a lot of head nodding
Okay,
for that.
I like head nods. So with that, you're allowed to go on your break. Thank you.